Okay, so good morning, the Professor Ying Xian from Taiwan. Good morning Professor Gao Xiaofei, um, and Professor Chen Gongyuan is the colleagues from Anzhen. And so today is the first session of it's one session. It's session TAVR. Is about update the 20 and the 25 and the new progress in the TAVR the field. And I'll be chairman with the Professor Yun Min An from the Anshan Medical Center, University of Assam College of the College Medicine, the South Korea. And another chairman is Mr. Professor Zhang Junjie from the Nanjing Medical University. And our another friends, the Mac Lee from Hong Kong, the Queen Elizabeth Hospital. So now we start our session. So I think it's here also welcome all the colleagues and the friends online to join this the Asia the meeting about the cardiology. So I should be the first speaker, but it's regarding to the antiplatelet, anti-thrombotic therapy, and in Fuai Hospital, and Professor Ye Yuqing is the main investigator. So at the moment we are organizing the clinical trial RCT. Its name is the TAVR. So now the trial is finished halfway, and maybe here we also report all the friends online and about our result. Okay, now the Professor Ye Yuqing, please.
Okay, good morning, professors. I'm Yin Qing from Fuai Hospital. It's my honor to give this presentation in this session on behalf of Professor Wu Yongjian. The title is about the contemporary optimal antithrombotic therapy in TAVR. The indications for TAVR have been expanded to low-risk patients. An increasing number of younger, lower-risk patients are expected to undergo TAVI. Lifelong management is required. Bioprosthetic valve durability is critical in the lifelong management strategy for TAVR. Valve thrombosis causes hemodynamic disturbances that reduce valve durability. Valvular degeneration leads to poor prognosis for TAVR patients, and thrombosis is the main potentially reversible cause of valve degeneration. So let's talk about the current view about the THV thrombosis. The high incidence of THV thrombosis was first reported in 2015 by Professor Makar. He found that the incidence of HOT in 4D-CT can be as high as 40%. Since then, there has been a lot of concern about the THV thrombosis. In the Partner 3 CD sub-study, the incidence of HOT at 30 days and 1 year after TAVR was significantly higher than that of SAVR. Known risk factors and the pathogenesis of HOT include endothelial injury, hypercoagulability, altered blood flow, neurosinus, and are related to the type of prosthetic valve deformation, dilation rate, size, implantation depth, and other factors. The relationship between HOT and the clinical outcomes remains inconclusive. Current studies have shown that HOT leads to valve deterioration, but whether it increases mortality is still controversial in different studies. Due to advanced age and comorbidities, Risks of bleeding and embolism are both increased in TAVR patients, so antithrombotic therapy after TAVR presents significant challenges. In pivotal low-risk patients, the one-year bleeding incidence after TAVR is about 7.7%. From France TAVI registry, anticoagulation was identified as an independent predictor for mortality. Due to the concerns about TAVR bleeding, early in TAVR, DAPT is recommended for 1 to 6 months after TAVR, followed by lifelong SAPT. The recommendation is based on PCI antithrombotic strategies, lack of large-scale, robust evidence, and focus only on clinical events, not THV thrombosis. Next, let's take a look at the research progress on antithrombotic strategies for TAVR. First, we discuss patients without OAC indications. Several studies have been conducted on antithrombotic strategies for TAVR without OAC indications, such as Popular TAVI, Galileo, Atlantis, Adapt TAVR, and so on. Popular TAVI cohort A compared aspirin plus clopidogrel for 3 months with aspirin alone. Popular TAVI cohort A study shows that in TAVR patients without indications for OAC, SAPT is superior to DAPT because SAPT significantly reduces bleeding events with 1 month and 1 year and doesn't increase the thromboembolic events. Based on the findings of Popular TAVI, guidelines have updated in the recommendation for antithrombotic treatment for TAVR. For patients without an OAC indication, lifelong SAPT after TAVR is recommended, Class 1 Evidence A. The Galileo study compared rivaroxaban plus aspirin for 3 months versus DAPT. In the midterm analysis, the risk of death, thromboembolism events, disabling or fatal major bleeding were all significantly higher in the rivaroxaban group than in the antiplatelet group, so the study was terminated early. Therefore, in the subsequent guidelines, the strategy of rivaroxaban in combination with aspirin is forbidden. The Atlantis study compared apixaban with antiplatelet regimens, and the results showed that apixaban and APT are comparable in terms of net clinical benefit, efficacy, and safety endpoints. But apixaban was superior to APT for valve thrombosis. In the low-risk TAVR study, which compared 1 month usage of warfarin plus aspirin with aspirin alone, the primary endpoint was the incidence of HOT. VK plus aspirin was superior to aspirin alone, and the safety of 2 groups was similar. This study suggests the safety of short-term anticoagulation. Short-term anticoagulation reduced HOT without increasing bleeding. In Adapt TAVR study, in terms of the incidence of 4D-CT valve thrombosis, edoxaban showed a trend toward superiority over DAPT. For new brain regions on MRI and change in cognitive function, there were no significant differences between edoxaban and DAPT. From the summary of these studies, for TAVR patients without OAC indications, OAC is superior to APT in preventing valve thrombosis. However, it failed to improve clinical outcomes. Next, let's talk about antithrombotic strategies for TAVR patients with OAC indications. Studies like Popular TAVI Cohort B, Atlantis Stratum 1, and Envisage. In Popular TAVI Cohort B study, for TAVR patients with OAC indication, OAC is superior to OAC plus APT. Since then, we know that TAVR antithrombotic therapy should follow the principle of the simpler, the better. The Atlantis Stratum 1 study found that apixaban warfarin was comparable in terms of clinical net benefit, efficacy, safety, and prosthetic valve thrombosis in TAVR patients with OAC indications. The Envisage TAVI AF study also showed that edoxaban was no inferior to VK in terms of net clinical benefit, but edoxaban increases the incidence of major bleeding, mostly gastrointestinal bleeding. Therefore, current studies have not shown the superiority of NOACs over VK in TAVR patients. Based on the research progress, ESC released the TAVI antithrombotic expert consensus in 2021. In 2022, the Chinese Society of Cardiology also released a Chinese expert consensus on TAVR antithrombotic therapy. The consensus mentioned when there is clear evidence of clinical leaflet thrombosis, consider VK therapy. It was also mentioned in 2023 Chinese clinical practice guidelines for TAVR. For TAVR patients with high risk of thrombosis, VK is recommended for 3 or 6 months. Now let's talk about the future research on antithrombotic strategy for TAVR. There are some ongoing researches on antithrombotic strategies in TAVR conducted in China and global. TAVR study is a randomized controlled study of TAVR antithrombotic strategy and conducted in 15 centers across China. Professor Wu Jian is the principal investigator. Studies compared 6 months VK followed by aspirin versus aspirin. It's a dual superiority design. We assumed that short usage of VKA can significantly decrease the incidence of heart and not increase major bleeding, therefore improve the net clinical composite endpoint. TAVR study started in September 2023 and expected finished by the end of 2025. The primary endpoint result will be reported in 2026. Protocol has been published in BMJ Open. Another scope study compared 1 month NOAC followed by SAPT versus SAPT. The primary endpoint is the net benefit endpoint in 1 year. It's also a superiority design. Notion 4 study compared 3 months DOAC followed by SAPT versus SAPT. The primary endpoint is HOT. It's also a superiority design conducted in Denmark. The enrollment began in 2021 and the primary endpoint results will be announced in 2026. There are also some studies comparing the feasibility of different antiplatelet strategies, such as 1 month DAPT followed by aspirin or clopidogrel, or comparing aspirin versus low-dose ticagrelor. Future study should focus on first, exploration of the mechanism and the patterns of prosthetic valve thrombosis after TAVR, and investigate the individualized optimal antithrombotic strategies to balance the bleeding and the thromboembolic risk. For example, evaluation of short-term anticoagulation regimens to reduce thrombosis formation without increasing bleeding risk, or using a multi-modal integrating imaging approach, including the AI techniques, prosthetic valve deformation, fluid dynamics, and hematologic biomarkers. That's all for my presentation. Thank you for your listening.
Okay, thank you. Professor Yun Qian. And so maybe here for Professor Yun Qian, our old friends, very good friends, and Professor Min, 那个 and also the Professor Xu Kai, Professor Gao Xiaofeng. Maybe the first time we report our title, the result, the certainly. So this the enrollment, all the patient, the enrollment will be the finish in the end of this year. So next year we will report our total result. So this the study the start from the 3 years ago. And I think at that time before the 320 and 21, 20 and 22. So that time most of study the focus on the mortality and also the safety. And so the strategy for the thrombosis after TAVR, the just for the mortality and the cardiovascular mortality and the bleeding. And it's the never focus on the leaflets, hawk and thrombosis. But so in full hospital, so because the every patient after the TAVR procedure, so we let the patient to receive the the CT the CT scanning in a different time after TAVR. For example, is the first month, 3 months, and 6 months. Sometimes the 12 months. And so this is also the national project. So is this project is the more than 20,000 TAVR cases included. And so we just study the CT the finding, but we find that the most of time uh, thrombosis in the left and heart occurs from the first month to 6 months, and then very rare after 6 months. So we start use the warfarin for the first 3 months, but now we already know. So the Dr. Sun Guangyan leads another trial, so they try to shorten the duration of the new vac, just 1 month. And another trial, Notion 4, is 3 months. So now the different reagent and the different the time. So I think it's through the different design of the RCT, we will know uh, for the patients after TAVR. So it's warfarin first or the platelet, antiplatelet first. So because at the moment according to the guideline, and so if the patient without anticoagulation, so everybody should receive the antiplatelet, just aspirin or maybe Plavix. So, but from our the data, so we have already data. So I think maybe the warfarin should be first in some patient, but it's also evaluate the bleeding risk and the efficacy through this also. Our next step, we'll try to find some um, um, indicators for the warfarin. For example, if the wall is the deformation is very severe, and maybe the small annulus, and maybe the volume grow. But and I think it's in the next step we will develop another trial, and maybe in the future. So anti-thrombosis strategy maybe should be the personal. Okay, so Professor Yuan and Professor Miller. Please give some comments and suggestions.
Uh, to me, because all these study were done in aging people, that means patient older than 80, and for those people, the bleeding risk is much higher than the thromboembolic risk with the use of NOAC or anticoagulant therapy. So no wonder the study will show, even though there is some benefit, but the bleeding risk was significantly higher. So, however, I just wonder, when we use TAVR in younger and low risk patient, should we consider this kind of risk? I mean, thromboembolic risk for younger patient. If it is, then in our center we adopt the surgical guideline. That means we use a short-term 3 to 6 months of uh, anticoagulant for 3 to 6 months, then switch to single antiplatelet. That's our strategy currently because the patient becomes younger, and you after all you put a surgical I mean put a bioprosthetic valve in the in the patient. So maybe we should consider these kind of things. Thank you.
Yes, thank you. So our idea is also from the cardiac surgeon because the 10 years ago, and so the many years in the last maybe 20 or 30 years. So for cardiac surgery, so they are very patient after a procedure. So they always let patients to take the warfarin for sometimes 3 months, sometimes the 6 months, and then you stop. Because that time there are no idea about antiplatelet treatment. And but I think it's the combined the some data and the last year, for example, Galileo and also the investigated TAVR. So now, so we launched this the new the trial. We hope to reduce the Hawk and thrombosis, although at the present, I think thrombosis and Hawk, because we have no not long enough like time to follow up. So what's the meaning uh, the thrombosis, the Hawk for the future? We don't know exactly, but I think is in our cases, if the thrombosis actually in the uh, leaflet, so it will be the induce the stroke. Yeah, so it's the one-to-one. So I'm sure. So the thrombosis is the significance. So, okay, and thank you, Professor Jing. And what about your opinion, Professor Michael?
You mean for the next session?
No, okay, maybe you can share the next section.
Oh, can I just express my opinion
Opinion.
first
Yeah.
on the anti-thrombotic antibody? Because I
Mm,
think it's going to be patient specific, as mentioned by Dr. Yin. I think for elderly, high bleeding risk patients, we might actually consider seriously before we give anti-thrombotics, like warfarin, either warfarin or NOAC, because sometimes these patients with high bleeding risk, uh, dual antiplatelet or even single antiplatelet might be good enough. And then
mhm,
probably we should also consider the size of the TAVI device. For smaller TAVI device, balloon expandable with high residual gradient, probably we should seriously consider anticoagulants for these patients. And also for younger patients, as mentioned by Dr. Yin, that we want to preserve the durability of the valve, probably we should give a short course, 3 months or 6 months anticoagulation, so that just tie them off with the early implantation of TAVI device so that they can have a better long-term outcome. I think it's going to be patient specific is in the future.
mhm,
Or as mentioned earlier in the lecture, AI-assisted management strategy would be also good. If we can measure the hemodynamics, measure all these inflammatory markers at the end of the procedure, then we can know how to specifically direct to patient-specific post-TAVI antithrombotic management in the future. I think it should
Okay.
be individualized. Thank you.
Yeah, thank you very much. So, do you think is the AI can be used for the prediction of the future event?
Yes, I
So,
think we can make use of AI, we can make use of big data, and then sort of give us a guidance, patient-specific, individualized antithrombotic treatment in the future.
okay,
I
thank
think
you.
because you are so strong, mainland China is so strong in AI, I think you should lead this project, AI sort of assisted prediction or algorithm to
Yeah.
predict which patients should give what kind of antithrombotic management in the future.
Yeah, thank you. I think we should do it together with the Professor Yin and Professor
Yes.
Maker and also other friends. So I think now the AI can be used in every field. I also try the AI for the evaluation before the procession. So now we also start to use the AI for the strategy made just for anti thrombosis strategy. Okay, thank you. Any other comments? The Professor you can.
Yes. Thank you. Very great session and a great lecture from team of Dr. Wu. So I totally agree with Professor Yin and Michael. Maybe in the future, individualized antithrombotic therapy is one of the options for the patients without the indication for the anticoagulation. And we are very honored to participate in with the auto study as one of the authors. So in the future, maybe we have to think about the age, the risk of thrombotic events, and also what kind of valve we implanted. So anyway, individualized therapy will be the future, and we also look forward to the result of Toyota and other ongoing studies. Maybe those studies will change the guideline in the future. So thank you so much.
Okay, thank you, Shikai. So Shikai is do a lot, so in TAVR and also the lot of the research. I really hope so. So we can work together. And what about the opinion, the comments from the Professor Gao Xiaofei? Do you have some comments?
Well, thank you. I did not have any comment. Thank you.
Okay. So maybe now, so and we should continue for this station. So the friends Zhang Mingyang from Seoul, Korea. So the Professor An already online.
I think he's not online.
It's not online. Okay. So the Mr. Zhang Junjie already live. So okay. So my colleague. So yeah, continue to chair this session. Okay.
Oh, okay. I saw Professor Gao Xiaofei is here. I think he's from Nanjing First Hospital. I think he's going to update us on the TAVRs in 2025. What's new? Please go ahead, Professor Gao.
Thank you. Let me share my screen. Thank you for the introduction. Can you see my slide? Okay.
Yes, we can see it well.
Yes, thank you. Good morning, everyone. Distinguished our professors. It's my great honor to introduce the TAVR updates in 2025. First, let's start with the pure AR particles regurgitation. The ALIGN-AR trial is a landmark study in AR management. And the initial data from 180 patients was published in the Lancet last year. And at this year's ICC conference, results from an expanded cohort of 500 patients were reported. The cohort had a mean age of 76 years and SDS score 3.9%, and the large valves were used in 51 cases. Procedure safety was robust, and no intra procedure days, and 1.6% of embolism, 0.6 of aortic dissection, and very good data. Surgery or intervention related to device or procedure 3.6%. At 30 days, follow-up all-cause mortality was 1.4%, disabling stroke 0.8%, and a new pacemaker implantation 23%, a little high. In patients with pure AR, TAVI significantly improved the left ventricular remodeling and the reductions in left ventricular end-systolic and diastolic volumes and the regression of left ventricular mass. However, pacemaker rates were notably higher in the large valve group compared with small or medium valves, nearly 29% versus 18%. Predictors of new pacemaker include a history of congestive heart failure, baseline severe AR, annular parameter equal or more than 85 millimeter, and baseline IBBB. So the conclusion of ALIGN-AR trial, the INNOVAV is uniquely designed for symptomatic severe AR patients. Following recent FDA approval, this device offers a critical option for high surgical risk. Its technical success, safety, and outcomes in ALIGN-AR trial support future randomized trial comparing INNOVAV to SAVA in low-risk AR patients. So the ARTIST trial is ongoing comparing TAVI with INNOVAV versus traditional surgical aortic valve replacement in 1,016 patients. The primary endpoint was all-cause death, any symptomatic stroke, and urgent cardiac rehospitalization at 12 months. It's a non-inferiority clinical trial. This prospective multi-center single-arm study reported at the EuroPCR 2025, enrolling 127 high-risk patients with symptomatic severe AR. All patients underwent transfemoral JVAL. Transfemoral JVAL, primary endpoint all-cause death at 12 months. Procedure outcomes, 0 procedure days, and then 0 stroke, 0 myocardial infarction, very good data, 2.4 conversion to SAVA, and no coronary obstruction, no aortic dissection. Totally nearly 94% technical success. At 30 days, all-cause death 1.6%, new pacemaker implantation 9.5%, very low. Major vascular complications 0.8%, and no stroke. At 1 year, all-cause death 3.2%, new pacemaker implantation nearly 13%, yeah, lower than INNOVAV. Major vascular complications 1.6%, stroke 2.4%. PVR intermediate after procedure, and moderate no severe PVR, and moderate PVR 2.4%. At 30 days reduced to 0.8%, and at 1 year is 0. No moderate or severe PVR. Consistent with the prior evidence, successful TAVI with GFR significantly with improved left ventricular function in AR patients with reduced LV-EDD and LV-ESD. Conclusions: the GFR transfemoral system has demonstrated the following factors in AR patients: low mortality and morbidity at 1 year, low new permanent pacemaker implantation, excellent hemodynamic valve performance. Also with ALV remodeling, improved ALV remodeling, and significant clinical functional improvement. Long-term evaluation of clinical outcomes and valve performance are on the way. So let's move to sorry. Okay. That's back. Okay. Just we discussed about the sorry. We discussed about the AR patients, and now let's move to the AS. As we all know, Everett low risk and the partner 3 trial, other milestone trial in AS patients, and at this year's conference, sorry, the 5-year follow-up of Everett low risk trial are reported. Sorry.
No.
Okay. Sorry. And okay. Okay. Well, we all know the result of this. Yes. We all know result of this study, and the Everett risk trial with Everett valve included in the enrolling the patients with low risk patients, and all these patients treated either Everett or surgery showed comparable rates of all-cause mortality or disabling stroke at 5 years. 15% Everett and 16% surgery. No significance, no difference, and the cardiac mortality was very similar for Everett and surgery at 5 years, and a significantly lower mean gradient and a larger UOA with Everett versus surgery. No difference in valve reintervention rates, moderate or greater PVR, and or alive, and the worst patient quality of life at 5 years. So the results of the Everett low risk trial at 5 years support Everett as a safe, effective, and durable alternative to surgery for patients with severe AS and low surgical risk. This is the study changed the guideline, and the guideline now recommend patients with at low risk can do their TAVI. Yeah. Sorry, and for early TAVI, and now we now the patients for the symptomatic symptomatic patients, moderate severe patients with no symptoms, we just follow up the patients and the clinical surveillance. The early TAVI patients is a prospective multi-center randomized trial evaluating patients with symptomatic severe AS aged more than 65 years old with CS score less than 10% and IVEF more than 50%. And all these patients randomized to transfemoral TAVI with setting 3 on setting 3 Ultra versus clinical surveillance. Primary endpoint was no hierarchical composite or all-cause deaths and stroke, and unplanned cardiovascular hospitalization after minimum follow-up of 2 years. Mean SDS score of very low, 1.8%, and like a bicuspid valve 8%. The early TAVI significantly reduced the composite endpoint of deaths, stroke, or unplanned cardiovascular hospitalization. Benefits emerges early, and a curve separation by 6 months. NNT only 6 at 2 years. No mortality difference, no stroke difference, The benefit of primary endpoint was mainly driven by fewer cardiovascular hospitalization. The curve is very similar with the primary endpoint. The curve separated before 6 months. This is a very interesting finding, and the median time to conversion to aortic valve replacement in the clinical surveillance group was just 11 months. Early TAVI prevented quality of life decline, improved left ventricular function, and had no excess mortality risk and no stroke risk. So the results of the early TAVI trial support TAVI as a safe, effective strategy for patients with asymptomatic severe AS. This article published in the New England Medicine, FDA has approved the setting 3 Ultra to treat patients with asymptomatic severe stenosis. We have discussed TAVI in low-risk patients and asymptomatic severe stenosis. A critical question remains, can TAVI benefit a moderate aortic stenosis patients? The TAVI enrolled trial was investigator-initiated international randomized trial to enroll symptomatic patients with moderate aortic stenosis and LVEF 20% to 50%. All patients were randomized to transfemoral TAVI group or clinical surveillance group with 89 patients each group, a small sample size. Due to a small sample size, the primary endpoint was hierarchical occurrence of cause death, disabling stroke, hospitalization, and change in KCCQ. And the first key secondary endpoint is MSCC MACE. No difference in MACE or mortality was found. In terms of quality of life, TAVI group demonstrated improvement in KCCQ score as early as 30 days. At 30 days, the curve separation. By 180 days, some patients in the control group had a crossover to receive TAVI. When excluding these crossover patients in the clinical surveillance group, the sustained benefit of quality of life became even more evident in TAVI group. In summary, the results of TAVI enrolled trial support TAVI as a safe, effective strategy for patients with systolic heart failure and moderate aortic stenosis. However, the TAVI enrolled trial had a very small sample size, less than 200 patients, limiting its ability to provide definitive conclusions. Currently, 2 large-scale trials, Progress trial and Expand TAVR2 trial, are ongoing, and will generate more robust evidence for clarify TAVI's role in moderate aortic stenosis with reduced LVEF. As an interventional cardiologist, we all pay close attention to the procedure complications. And this study for the patients' level data from 10 clinical studies, including 24,000 TAVR patients between 2007 and 2022. The overall surgical buyout rate was 0.52%, very low, declining from 0.84% to in 2007 and 2010 to 0.25% in 2019 to 2022. While these rates are very low, but the outcomes for buyout cases remain very poor. In hospital, survival rate was only 52%, and the 1-year survival dropped to 31%. Let's break down the causes. I think as an interventional cardiologist, this data are very important. In patients with balloon expanded valve, annular rupture 24%, ventricular performance 20%, and valve malposition 15%. In patients with self-expanded valve, ventricular population, ventricular population, yeah, 39%, and the valve positioning, 22%, coronary obstruction, 7.4%, and annular rupture only 3.7%. In summary, surgical buyout is infrequent and decreasing over time. Ventricular perforation was the most prevalent reason for surgical buyout, totally 28%. France TAVI registry focused on coronary events after TAVI, and this trial included data from all patients who had undergone TAVI in 48 or 50 TAVI care centers in France. After discharge, first hospitalization for coronary events occurred in 11.6% of cases. The yearly incidence was very low, only 1.5 per year, percent per year. Predictors of coronary events after TAVI discharge was male, younger patients, dyslipidemia, knowing coronary artery disease, peripheral artery disease, coronary lesion more than 50% before TAVI, STEMI during TAVI index hospitalization. For patients with knowing coronary artery disease, peripheral artery disease, and coronary region more than 50% before TAVI, interventional cardiologists tend to prefer balloon expanded valve. This is a very important review in TAVI procedure, published in Eurointervention on the management of complications after TAVI. It provides a comprehensive overview of common post-TAVI complications and their management strategies, including stroke, conduction disturbance, PVL, annular rupture, and coronary obstruction and vascular complications. This review is essential reading for early career physicians, help their understanding of TAVI-related challenges. 2025 has brought transformative TAVI evidence, expanding indications for aortic regurgitation, proactive strategies for symptomatic aortic stenosis, and insights into moderate aortic stenosis and heart failure. This advantage demand a paradigm shift. TAVI is no longer just for high-risk patients. And thank you for your listening. It's my presentation. Thank you.
Thank you. Great. That's very comprehensive view of what's happening in 2025. I would say it's an exciting year. You see the new devices coming out to treat pure aortic regurgitation patients, and then the low risk trials coming out so that we can treat lower and lower risk patients, younger and younger patients. And now in the US, they are treating patients older than 65 years of age. And then all those asymptomatic severe AS or moderate AS with heart failure patients, I think those areas are still under active research. You don't see really mortality benefit when we treat patients with asymptomatic severe AS, but hospitalization definitely has been reduced. And if you look at the manuscript itself, I think the late events, the late stroke events, actually are much lower if we treat the patients early with TAVR instead of observing the patients. That's something that we need to explore further still. And then I like the bailout study, because you see very, very high mortality when we have to ask our surgeons to do a bailout procedure. And we have to understand why this happens. And we are glad to see that the incidence of bailout actually have been declining over the years. So we are providing safer and safer treatment for our patients with TAVI, and ask our surgeons to bail out ourselves much less in the recent years. So that's something we really want to see. And then all those complication management, again, is very important, especially for all those early TAVI operators. So very, very nice presentation, Professor Gao. Any comments from our panelists? Professor
Okay,
Yin and
yeah.
Professor Xu. Okay.
So to make agree with you,
Yeah.
so the last year, so this it's very special year. So I think it's the most of the trial maybe they start from the COVID-19. So now and all the trial is finished. So now we can get know the result. And I think from the 5 years ago, so maybe the and the 1990, 2190, maybe this year, because this year is the CP3 and avatar risk to finish. So that means that that's the period of TAVR study is finished, because from the 20 to 10 and the 20 to 19, so it's the all 10 years and indication for the TAVR is the main problem. So because from beginning, so indicator for TAVR is it's a very high risk, also inoperable the patient. So that's the decision, the indication for TAVR. But up to the 2019, so the indication the move to the low risk. But I think this is the first step. And after that, so the study, the trial, and move to the different condition of the clinical situation. For example, for the combined with the coronary heart disease, and also the indication more for the forward, right, for the unloading TAVR, and also medical patients, the patient can be treated. So I think this is very, very the big progress. And on the other hand, so device the design and the new design development becomes slowly. But in China, and this year maybe the two different devices just for pure AR can be get the approval from the AMP. But for the other kind of the devices, there's not many than before. So this is maybe this is the characteristic of the new year. We will know in the future, in the next few years. So and folks also focus on the different situation of the disease. I'm sure. Okay. Thank you. The very good the presentation from the Gao Xiaofei. Okay, thank you.
Great. Do we have comments from Professor Yin and Professor Xu? Yeah. Prof. Yin, maybe you go first.
I think Professor Gao have done a great job, and also comments from Michael and Jian. I just wonder, with dedicated bar for pure AR, do you think there is still a room for conventional TAVR devices off-label use, such as the study done in Nanjing?
Yes, I think it's a good question. Yeah. The dedicated device, just like InnoValve, transfemoral valve, I think in the future is the best, maybe currently is the best device for the aortic regurgitation. And last month, we have finished the enrollment of patients of our season AI trial. And I think it's different study. Our study just comparing TAVR and the GDMT in the high-risk patients with AR. And we just want to answer the question for now, just no randomized trial. And we just want to answer for all these patients, high-risk patients, and now only surgery, and compared with GDMT, the safety and efficacy of TAVI. maybe if our studies, for example, I don't know the result, and maybe it's a positive result, positive result. Maybe in the future, if we use the dedicated device, we have a better clinical outcome. Yeah.
Yeah,
Professor Shukai, you have comments?
So, no more comments. Thank you, Dr. Gao. Wonderful lecture. Thank you.
Thank you.
But I think because with some of the new device, the specifically for the AR, so in the future maybe our strategy for the AR maybe is the change, and because in China the AI the prevalence is much higher than the Western countries, and including the different segment of uh, the different state of the whole life. And according to the full hospital, so the patient, the age less than the 16, they're 16. So it's the 6 to 17% ER, but it's more than the 6 years old. It's nearly the 22 or 20 or 25. So it's very high. So I think we are all the physicians are waiting for the new device, because now the regular device is a little bit the danger for some patients. It's risk, but I sure so. And from the last several the RCT trial from Nanjing, from Anjing, and from Shanghai. So now we have already get a lot of experiments about the self-expandable device. I think it can be used in but maybe the 20 to 30% among all the AR patients. So this can get the good result. But it's and another patient we're not sure. So and in some patient, for example, is there the diameter is very large, so we can't the trial. But this is the current status of China for the AR. Maybe next year we will change. Okay.
Great. Shall we move on, Professor Wu?
Yeah. Because the friends from the Korea is not here, and so Miko, do you want and you should continue to check the next speaker.
Okay. It's my honor to introduce the next speaker, Professor Yin Weixian from Zhenqing General Hospital in Taiwan, Taipei. He's an expert in TAVI and all sorts of structural interventional and coronary interventional procedures. And today he's going to talk to us on the redo TAVR, some of the tips and tricks. I think he's doing a lot of redo TAVR nowadays, and he's the perfect person to talk to us on this topic. Professor Yin, please go ahead.
Thank you, Michael. Can you see my slides?
Yeah, clear.
Yes, we can.
Yeah, thank you very much for inviting me to join this wonderful session. My topic today is to discuss about the tips and tricks for redo TAVR. As mentioned before, TAVR has become the first-line treatment in low risk and patient older than 75. However, dysfunction of a biprosthetic valve is a well-known entity that occurs with SAVR and TAVR devices. So finally, the valve might become degenerated and even failed in the long run. So when the surgical or transcatheter biprosthetic valve fail, you can treat the patient with reduced surgery or valve-involved TAVR. For those with surgical valve, TAVR itself is the way to go because it is easier to do than redo SAVR. And for those patients with transcatheter heart valve failure, TAV in TAV is better than TAVR explantation because the surgical risk associated with TAVR explantation was really high, so this was not negligible. Therefore, redo TAVR prefer over surgical explantation. So we can anticipate that in the near future, within 5 to 10 years, there will be a tsunami of valve-involved TAVR, no matter in surgical or transcatheter bioprosthetic failure. It is anticipated that up to by 2034, the demand of TAVR-in-7 and TAVR-in-TAV procedure will be increased significantly, with project to 40,000 cases per year. The complexity of redo TAVR depends on the interplay between arterial anatomy and the valve combinations. There are 4 possible combinations for redo TAVR procedure. That means a tall frame valve in the tall frame valve, or short frame valve in the tall frame valve, or tall frame valve in the short frame valve, or short frame valve in the short frame valve. The key to successful implantation of a second valve lies in addressing coronary risk and the reaxis and hemodynamic performance, conventional misalignment, frame expansion, and the circularity of the different device combinations. In our center, we adapt the so-called 4S approach. That means we consider valve selection first, then doing sizing, and stratify the coronary and the hemodynamic risk, and finally we determine the optimal valve seating position. Regarding valve selection, in our center, we have analyzed our 40 cases of valve-involved TAVR, no matter it is a repeat TAVR 1 or a redo TAVR 1. For this patient, we divide them into 2 groups based on whether the index valve was a tall frame or a short frame valve. The primary endpoint was coronary obstruction risk, determined by inaccessibility to the coronary artery, or the pre-procedure CT demonstrated extreme high risk, and we also consider power leaks and hemodynamic performance of the TAVR-in-TAVR procedure. In our study, we found that although there has been no significant difference between the 2 groups, the instance of a significant PVL and the coronary risk were numerically higher with the index valve when the index valve was a tall frame valve. On the other hand, the instance of hemodynamic structure failure or deterioration, I do not mean the failure, it's a hemodynamic SVD was higher in patients with those whose index valve was a short frame valve. This was also similar when you divide the patient into 4 subgroups: tall in tall, short in tall, tall in short, and the short in short. As you can see, due to the presence of a tall double skirts, resulting in a high neoskirt in the tall in tall combination, the instance of different called coronary reaxis and the PVL were higher. These are 2 examples showing that in the left panel, you can see the patient have a conventional misalignment, tall in tall combination, and the implantation depth was high, so the patient cannot have a successful coronary reaxis after TAVR-in-TAV. On the right panel, PCI can still be done because the patient has a better conventional alignment in a tall-in-tall combination, and the implantation depth was deeper. This allows the wiring of the coronary artery, even though fully engagement of guiding catheter was failed. We can still do the procedure with extension catheter. It is reported that after toe-in-toe combination, as you can see, the risk of coronary obstruction or sinus sequestration was significantly higher in patients with toe-in-toe combination. On the contrary, it is easier to get successful coronary access with a short combination. However, this may change in the future because the introduction of FX Plus system with a large coronary access side hole that may change the whole scenario. That means in the future, maybe toe-in-toe combination is an acceptable one because it can provide better hemodynamic performance in the index valve during the first TAVR implantation. Regarding the hemodynamic following redo TAVR, up to now, severe patient-positive mismatch is associated with an increased 1-year all-cause mortality. Among the 4 different combinations, as you can see, although the toe-in-toe combination has better hemodynamic performance, however, we have discussed previously that coronary risk was the highest, so it should be avoided. For the other 3 combinations, toe-in-short, short-in-toe, and short-in-short, the hemodynamic performance determined on the index valve size. That means if the index valve was smaller in size, the hemodynamic performance will be compromised. So in summary, different valve combinations have their respective advantage, disadvantage, and specific considerations during redo TAVR procedure. So careful selection of valve combinations, valve size of the second valve based on CT, and the meticulous procedure planning are crucial to ensure successful redo TAVR procedure. And we up to now, a toe-in-toe combination should be avoided. Regarding sizing, proper sizing is crucial when selecting the second transcatheter heart valve. This case, we use a 26 Sapien 3 in a failed 26 Sapien 3 valve. This was an intuitive choice, but as you can see, it ended up with a pinwheeling effect and leading to increased pressure gradient. So this may compromise long-term durability. Why this would happen? Because the thickness of the first transcatheter heart valve leaflet and the potential for incomplete expansion, for example, under fear of the balloon during the initial implantation may result in the internal dimension of the first valve different from the expected size. This may necessitate resizing based on preoperative CT for the second procedure. That means sometimes downsizing of the second valve is required. As demonstrated in this patient, the inflow and the waste was measured with a diameter for only 20 to 21, even though the outflow was 27. So in this failed 26 core valve, we chose a short-in-toe combination with the use of 20 millimeter Sapien 3 overfill 1 cc. As you can see, the final result was really good, and only 6 millimeter residual gradient was demonstrated. Regarding the coronary risk, we use the classification. As you can see in the classification of coronary risk based on coronary height and the size of the aortic root. If the aortic root anatomy was really small, and the STJ or sinus valsalva was shallow, and the coronary height was low, then the coronary risk was higher. In this patient, you may need leaflet modification, chimney stenting, or even surgical explantation. This is a patient with a surgical valve failure in 2016. We put the 23 Sapien XT at that time because we don't have the concept of bioprosthetic valve fracture at that time. So the procedure end up with a significant residual gradient of 25. This valve, this transcatheter valve failed in 2024. We did redo TAVR after balloon bioprosthetic valve fracture with a 22 balloon, followed by implantation of 23 millimeter FX. And this time, as you can see, the procedure was really successful, even after 3 valve implant. That means TAVR in SAVR. And the residual pressure gradient was 7 millimeter only. That means if the patient have a very satisfactory root anatomy, you can do whatever you want. Even a 3 valve can be put in. And also, if you follow the state-of-the-art practice of TAVR in TAVR or TAVR in SAVR, you can achieve a very good final result. This is another example. The patient have a 29 XT as the index valve. As you can see, when you measure from the CT, the patient's SOV was really shallow, even effaced. So based on CT measurement, the diameter was 24 to 26. So we chose 26 Sapien 3 and use a unicorn procedure. And finally, we successfully deployed Sapien 3 26 millimeter inside with a short combination. Regarding the optimal valve seating, in our center, we don't care really much about the node. We don't count node at all. We just respect the native anatomy of the patient. That means we aim the upper rim or the inner skirt of the second valve to keep the neo skirt below the coronary takeoff. This should be done with high pressure balloon inflation. Expanded the first TAVR valve within the safe range, avoiding overexpansion because overexpansion may compromise VTC. In such a safer dilatation of the second valve, you can achieve a better pressure gradient and the PVL result finally. So these are the coronary alignment during the valve implantation for all 4 combinations. That means we should align the neo skirt of the second valve below the low edge of the low current Austin. This is a simpler and more intuitive and precise approach that can minimize coronary issue. So in conclusion, TAVR in TAVR or redo TAVR are an acceptable alternative to redo open surgery for patients with transcatheter heart valve failure, and this will be increasingly used in the near future. The key to success is an understanding of the index valve and the result, and the meticulous planning to minimize patient risk, including selection of the appropriate device, proper sizing, and pay attention to the implantation depth. In redo TAVR, coronary risk and the hemodynamic performance are major concerns regarding optimal procedure result. Leaflet modification chimney stenting or even surgical explantation may be needed in patients with extremely high risk for coronary obstruction and or sinus sequestration. When treating young patients with a longer life expectancy, the lifetime management must be considered and anticipated by the heart team while planning the index TAVR procedure. I thank you for your attention.
Thank you, Professor Yin. That's really a brilliant summary of how we should consider what we should consider when we have to redo TAVI procedure. So the summary slide says a lot on how we should choose the different types of device for redo TAVR, like the short or tall device, and then the sizing is very important. Risk of coronary obstruction, and finally the position where to put the second valve again is very, very important. But it all comes with experience. We have to do more of these procedures before we can really master it well. And as mentioned by Professor Yin, the incidence of TAVR in TAVR or even in TAVR will be increasing dramatically in the very near future because our patients are coming back with failed valve prosthesis, with failed TAVI device, and somehow we need to treat these patients in the future. Let's see if we have any. Yes. Maybe I can start just one question, Professor Yin. When we do TAV in TAV, do we need to consider fracturing or modification of the first TAVR device if we see really a high gradient? Can we break the valve?
Yes, you are right. Yes, you are right. Because as I mentioned, usually the true ID you measure from the CT was smaller than you anticipated. Especially for those patients with a significant high residual gradient of the first valve or stenotic mechanism of the index valve. You should do aggressive dilatation, but that should be done in a safe range. As I mentioned, if you do too aggressive over expansion of the index valve, that may compromise the VTC distance and result in a higher coronary risk afterward. So you are right. With both consideration of the positioning of the second valve and the aggressive dilatation of the index valve, usually we can achieve a better result hemodynamically. Thank you.
Thank you. Professor Wu?
Yeah, I think it's the report from the professor is very, very important. I'm sure in the next 5 to 10 years, so this is the big problem because now with the increased number of the TAVR cases year by year, and I think it's because now it's just the risk years, so the most of patients to receive the TAVR, so they are the relatively younger. For example, 16 to 17 years old. But I think for the very high patients, no problem. But for the low risk and low age, the patient after 10 years, it's a bigger problem, especially for the small anatomy. So I mean small annulus, small and sinus. So this is really the risk for the redo TAVR. And I did agree with the Professor Michael. So for the field, the THV, I think for TAVR and SAVR, because for example, the patient and 10 years ago he received the surgical treatment, and another one is the same the size, but I received the TAVR. But I think it's also the different strategy for the redo. If the normally we know, so for the cardiac surgeon, so normally they select a relatively small valve But for the TAVR operator, they try to use the larger. So if the surgical valve failed, so maybe we can use the big balloon to make the bigger, because we also analysis the original diameter. So we can use the big balloon to make the bigger. But for the TAVR patient, because this the original analysis is small, so we can't use the big balloon to dilate again. So I think maybe in future for the small for the field THV, we should redo TAVR. Maybe it's different. Yeah. Okay.
Yes,
So
also
the
great. Yeah.
Transcaster half valve cannot be fractured.
yeah
So it
yeah
is a different scenario between these two approaches. Yeah.
yeah. And so Professor Yin and Professor Michael and other friends. And so recently in Fuai Hospital, we launched one trial just for the small, very small annulus. So that means is the annulus size is less than the 745. But regularly is if the annulus the less than 430, it's called small annulus. But it's some patients can be used the 26 or 29 self-expandable device. I think it's not a real the small annulus. But if the annulus area is less than the 340, it's real. So it's bad outcome in future. So now we launched the new the trial and one group uh, in Taiwan, another group in several. So, but in several, so they must make the bigger the numbers, and then they implant the surgical the valve. And maybe I really hope to Professor Yan and Professor Menchu make Michael to support us. So this because we work together with the cutting surgeon. So because in Full Hospital, many the patients, so maybe we can get to know. So for the very small, so it's a very small analysis size. So maybe we should at the beginning we should a different strategy. Okay. So shall we move to the last speaker? Okay, last speaker is because the Dr. Sun Guangyan is busy with nonsense, so that just let's the Professor Yao Jing can talk. Okay.
Yeah. So can you see my slides?
The moment no.
Yes, we can see it now.
Yeah.
Okay.
It's already here. Okay.
So yeah, first of all, I must apologize. Dr. Stone has just get the emergency call by the hospital. So it's turned out my great honor to be here to share with you our kind of three techniques or strategy in our center addressing TAVR. So the first is the kind of new concept of the AR TAVR. The second one is the all-in-one technique in the minimalist TAVR. And the third one is the TPPM, temporary pacemaker technique after the TAVR. So as we know, the prevalence of the AR in mainland of China is quite higher, which is the opposite in Western countries. The prevalence of AI is higher than AS, as shown in the China DVD study led by Professor Wu Yongjian. We can see the AR prevalence is higher, which make the AR in China is a big issue. And Also, the prognosis of the AI is quite not optimized. So actually, I have a hypothesis here. The reason why we have a higher prevalence of AI in mainland China, is it mainly because of the lower control rate of the hypertension? It's just my hypothesis. I don't think there is kind of we can evidence to verify it. Anyway, so because of the even nowadays we don't have the dedicated devices launched in the China, so we launched a Aurora trial using a conventional device in 19 centers in China. So this trial is basically, we call it Aurora trial, is basically we use the microport device, and this is a self-expanding valve, of course. And we basically divide the three parts of native anatomy to call it ascending aorta, LVOT, and the annulus area. These three parts can give us anchor part of the device. So if the three parts can give us the oversize rate of 10%, we call it type 1. And if it's only two part of them, we call it type 2 or type 3. If there's only one part or even no part of the three part can give us oversize rate, we call it type 4. So in this classification, we enrolled type 1 to type 3 in our trial. So the concept here is basically original from the multi-plane measurements. We did it in we did it in regular AS TAVR, and we elaborate the how we do the multiple plane measurements in the AS patient. This is very recently accepted by the JCC intervention. And so we measure the LVOT as usual. We trace the contrast edge of the LVOT. So the measurement of the LVOT and annulus is quite same as the conventional way. The tricky part of the measurement here is the superannulus measurement. So everyone can get a different superannulus measurement, either in the AS patient or AI patient. Actually, we try to standardize the measurement. So here we use the kind of reproducible measurement. So the superannulus measurement is based on the perfect circle defined by the 3 point. This 3 point is the commercial point. So using this measurement, we can get a reproducible measurement of superannulus. So no matter who analyzed the pre-TAVR CT, we can get the pretty much same result. So this is basically the overall result of the Aura trial, which is also very recently accepted by your intervention. And we can see here, let's just quick look of the three types of the Aura classification. So this case, we can see the LVOT is 26.6 from the 4 millimeter below the annulus. And the annulus, the annulus area doesn't mean the annulus itself, but also means the annulus and above area. So we all know that the annulus is a visual annulus, not the anatomical annulus. So the anatomical annulus is kind of like Crohn's site. So it is from the annulus, visual annulus to the above anatomy. So we measure the annulus, the visual annulus, and also the superannulus from the annulus to 8 millimeter above the annulus. So you can see the annulus is quite okay, and also the superannulus area is from 2 millimeter to the 80 millimeter is kind of suitable, which means it's more than 10% oversize rate, according to the largest micro support valve. So this is the typical class 1 classification. And we can see if we have high rate pacing and deploy the valve to the biggest part. And if we are satisfied with the depth, and we can basically, because of the anchor site is quite good, we can basically, without the high pacing for the fully deployment, and we get a good result. And also we can quick look at the class 2 size. So this is the LVOT is quite large. So LVOT cannot give us the oversized rate. But the annulus from the annulus is quite big. The parameter derived diameter is 28.5, but the superannulus side, the superannulus the measurement is suitable from the 2 millimeter to 6 millimeter. We have so we not focus on the oversizing, how much the oversizing rate the native anatomy can give us, but we focus on the how much length the anatomy, the native anatomy can give us. So here for this case, we can get like at least 6 millimeter to 8 millimeter length. The native anatomy can give us oversized rate, and also about the ascending aorta, they can give us like a 22 oversized rate, which is good. So this is a class 2, and from even we have a large RVOT, we still can get a good result. So it's basically the same as the class 2, class 3. We have a big ascending aorta, which can not give us anchor site, but we have a suitable LVOT and annulus. Even the oversizing rate is not that big, but the oversizing, the length the native anatomy can give us is quite suitable. So we still can get good results. So let's see the final result of our Aurora trial using the conventional device. So the mean age is 77. The STS is quite higher, and the process valve size is basically the largest one gets the most part. And the result is we have 9 patients get valve involved in the procedure, which makes our device failure. So we get a device success as 91%, which is quite high. And we get a very acceptable pacemaker rate, which is also 9%. So basically, we have a good result with the conventional conventional device. And we also can see the left ventricle reverse remodeling after the procedure. So, and we also did the post-procedure CT analysis. We're using finite analysis to calculate the contact force between the device and the native tissues. So the basic result is we can see the superannulus, the part between annulus and STJ is the highest, get the highest force. So which means the anatomical annulus, not the visual annulus, can give us the anchor site for the device, which is a kind of a new concept of the AI TAVR. So, and this is 1 year clinical outcomes, and this is they will be very soon published in the European. And so yeah, we got a very good result using a conventional device in AI TAVR. So, but I like to back to the question asked by Professor Ying. We certainly can discuss the answer from there to here, but if you make me to choose yes or no, my answer might be no. Even we have actually at least a acceptable result from the conventional device, but I think this might be the best we can get from the conventional device. Our center are also the leading center for the Alta trial, which is using the TOS Trio valve, which is actually the same valve of the trilogy valve by the inner valve. So Dr. Song is the coordinator investigator of the Alta trial. This trial is enrolled 116 patients and in 19 hospitals in China. And the result and also very recently the outpatient get completed the 1 year follow-up. So these results are already disclosed in Europe PCR very recently, and we can quick look at the results. So the age is almost the same as Aurora, 70-ish. STS score is it actually is a little bit higher than the Align AI trial. AI trial is 4 point something, and yeah. And the echo characteristics and the city characteristics is quite similar with the Align AI trial, and we get the endless parameter mean endless parameter 80-ish. And the implanted size of device is actually similar with the Align trial. And also we can see the biggest valve get the biggest part. And okay, so so the most interesting part is the safety outcomes. In all these patients, 116 patients, only one case get the valve embolism. So the valve popped out after deployment. Actually, after we review the case, we could say we can avoid the embolization uh, if we uh, if we check the depths of the valve more carefully with the case, we might avoid the embolization. So we might get the 100% device success. So this just one case embolization got the device failure and got the device success at the 99.1% rate, which is quite favorable. And of course, the mortality is lower. And this is a quick look of between the Alta AI trial and the Align trial. So it's basically the same device, but Alta trial is after the Align trial. So we can see this is not a statistical comparison, but we can see the numbers here. So the safety endpoint is lower in the Alta AI trial, and especially the new pacemaker implantation is quite lower. It's 12.1, and in AI trial is 24%. I think the reason might be because we are after Eli trial, so we get more experience. So we are tended to choose a smaller device. Why when the anatomy is when the annulus is at the edge between two devices, which makes a kind of smaller oversized rate. And the other thing is in some centers of mainland China, we use a TPPM technique, which I will elaborate details later. So which might decrease some pacemaker implantation. And of course, the hemodynamic valve performance and the peripheral leak is quite good. And we can also see the left ventricular reverse remodeling after the procedure. And the quality life is definitely good. So how can I say? Dedicated device is dedicated. It's quite we get a quite a success, a favorable result of the device success of the safety endpoint of the primary endpoint. So and in the conventional days, I think the AI TAVR is kind of more risky than the AS TAVR. And now using the dedicated device, I think the AI TAVR is much safer than AS TAVR again. So back to the question, I I don't think there is there is a position for conventional device in AI TAVR in future. But our attempting use this, no, I don't think so, because we actually using the conventional AI device, we kind of understanding the anatomy more clearly, more to the truth. So even with the and also with the superannulus measurement, we can use it in the dedicated device also. And the second technique in our center is typically is all-in-one technique. So it's kind of a minimal technique, minimalized technique. So as we know, the in the very beginning, TAVR is kind of very you have to perform in the OR or at least the hybrid cath lab, but and more and more, and as time goes, the TAVR gets more and more minimal. So but the question is, can we get more and more minimized invasive? So the traditional TAVR is at least use the two artery access, basically the two femoral access, and then we, after the access complication gets lower and lower, we don't need the femoral access to be back up, so we switch to the secondary artery access to the radial. And in our center, we even not use the radial access, we just use the only one artery access, or even we discuss the venous access. So the tricky part, so this is how we are doing the all-in-one technique. We just push insert the 5 French catheter sheath to the big sheath, and insert with the 5 French pigtail. So this primary access and the secondary access using a same way. And the tricky part is actually the bigger sheath, as in most cases is 20 French sheath, is not compatible with the capsule and the 5 French pigtail, but it's compatible with the shaft of the delivery system and the pigtail catheter. So after we advancing the capsule into the descending aorta, we can thereafter advancing the pigtail to the ascending. So and we also invented a kind of new sheath to facilitate this technique, which has a side port can insert the 5 French pigtail. And we kind of using a retrogradely comparison between the traditional standard procedure and all-in-one procedure. And so we basically get shorter procedure duration and even kind of lower X-ray time, and with the basically same result. And this is the patent of the new device, new sheath. So the final technique is the TPPM technique. And as we also know, the heart block is kind of a big issue after TAVI. So we can skip this. And we can also see in some patients after TAVI, when they get the heart block and when they get the permanent pacemaker, and a year after, when we check the pacemaker, we find the pacemaker doesn't work because the patient get the rhythm back. So this is basically our pilot study. We used in 21 patients in TPPM, we get basically 5%, 50%, sorry, 50% rate lower pacemaker implantation. So this is how we do the TPPM. We just use the basically the similar way as the permanent pacemaker, but we just put the battery outside the body, not inside the skin. And yeah, so this is published in the last year in clinical medicine. So, and we basically get the nearly 50% rate lower pacemaker rate. And also we are now launching the RCT, compressing the TBPM way and versus the traditional temporary pacing in TAVR patient. We are have the hypothesis to reduce the pacemaker implantation rate by at least 20%. So yeah. So basically, this is our the daily use they use the technique in our center. So this is a kind of new concept of AI TAVR and all-in-one technique in the reduced access and also the TPPM. So that's it. Thank you.
Okay, thank you, the Professor Yao Jing. So the last year's the Guoyan and Yao Jing his team has done a lot, and so it's a lot for the new innovation and have to try the new devices and different the method and. But now we have so now the time is also delayed by the 15 minutes, so maybe we have no time to discussion, and maybe we can end here. And the Professor GM, Professor Michael, and Professor Shukai. Okay, thank you all, and hope to see you again. Okay.
Thank you.
Okay, bye.
Thank you,
Thank you.
bye
Enjoy.
bye.
Okay,
Thank you.
拜拜，哎，一个人再见，好，再见。
再见，
谢谢
再见，
哎
感谢 Michael，感谢殷教授。
再见。